Bone marrow edema is the generic term classically used to describe the high signal intensity alterations detected on magnetic resonance fluid sensitive sequences. These imaging abnormalities may occur in several pathological conditions associated with a broad range of symptoms. The condition most often associated with bone marrow edema is trauma, namely the occurrence of bone contusion manifested on MRI as high signal intensity on T2 weighted images. The histologic features indicate that such lesions represent areas of bone impaction and bleeding caused by trauma. These lesions are reversible and resolve in approximately 2 to 4 months. Some of the most prevalent conditions associated with bone marrow edema include bone contusion with rupture of the anterior cruciate ligament, and impaction of the lateral femoral condyle into the posterolateral tibia plateau, pivot shift, and lateral contusion of the lateral femoral condyle by the patella in patellar luxation. Bone marrow edema also occurred in so-called transient bone marrow edema syndromes, which is a generic term used for conditions characterized by diffuse prearticular high signal intensity on MRI and favorable clinical progression with complete resolution of symptoms. Some of these conditions include transient osteoporosis, regional migratory osteoporosis, and complex regional pain syndrome. Transient osteoporosis mainly affects the proximal end of the femur of pregnant or prenatal women. Regional migratory osteoporosis affects the hip, knee, and metatarsus mainly among middle-aged men. And complex regional pain syndrome usually follows trauma, often presenting pain greater than expected for the causative injury. Currently, transient osteoporosis of the hip, regional migratory osteoporosis, and spontaneous osteonecrosis of the knee, sunk, are believed to be indicative of subchondral fractures whose fracture lines are not always detected on MRI. Bone marrow edema is also found on MRI images of patients with sunk, spontaneous osteonecrosis of the knee, which is currently considered a subchondral insufficiency fracture. Therefore, the high signal intensity detected in this situation can be called bone marrow lesion, BML, reflecting this structural lesion of subchondral bone rather than regional edema, bone marrow edema.
Spontaneous osteonecrosis of the knee, also known as Albach's disease, involves the sudden onset of severe pain in the knee, which occurs from a lack of blood supply to the medial femoral condyle, resulting in a segment of the bone dying. Symptoms of the condition include tenderness of the medial femoral condyle and pain and stiffness in the knee joint.
The significance of BML, spontaneous osteonecrosis of the knee, SONG, which is currently considered a subchondral insufficiency fracture and can be called bone marrow lesion, for the patient's clinical condition and the prognosis of the affected joint are being increasingly investigated and discussed. In this video presentation, we aim to discuss the cause, histology, imaging characteristics, clinical presentation, and treatment of insufficiency fractures. Despite some proposal for classification of BME, bone marrow edema, there is still no consensus in the literature. However, we will try to address a type of injury that is believed to be central to the growing interest in this subject: the fracture due to bone insufficiency. Situations characterized by subchondral insufficiency tends to occur among older patients, mostly in women.
And this is an example of what we see from time to time where a patient will have pain and they'll go to their doctor and say, hey, I have a hip or knee pain or shoulder pain. They get an x-ray, and the x-ray is pretty normal for the patient's age. This patient was 62. They had some just minimal arthritic change, so they're reassured by their doctor and say, hey, you're fine. Just take it easy. Maybe take some ibuprofen. There's really nothing to do, and looks within normal limits, and maybe even the arthritis could explain your symptoms. So the patient continues to hurt. The insurance company is not going to pay for an MRI because there's no solid indication, but they will maybe let the patient do physical therapy for 6 to 10 weeks. And if it still hurts after all that time, then maybe they could approve an MRI. So the patient doesn't want to do physical therapy for all that time. They pay for their own MRI. And here we see the patient does have lots of marrow edema throughout the medial femur. And this is an insufficiency type fracture that's developing. And over time, this can go into collapse, and the patient may even need a knee replacement if it's not caught and treated. So this is an example of where our medical system is failing, and on occasion, again, this is not that common, but on occasion, a patient like this will be denied an MRI when really they need an MRI right away just to make an accurate diagnosis and get them the quick treatment that they really need.
Meniscal lesions are frequently associated with this situation, particularly large radial and root lesions, which may result in meniscus extrusion and loss of function. Chondral lesions are also common, such as cartilage thinning in the affected compartment or focal chondral injury.
It does look like an insufficiency type fracture. Now, this patient did not have much in the way of injury, just a minor injury. And the edema is far out of proportion to what would be expected. So they may have underlying alcoholism, steroid use, or people who have sickle cell disease or myeloproliferative disorders can cause this, but their marrow looks very good on this. In older patients, if they're older than 65, especially female, think about osteoporosis, the weak bone that can cause an insufficiency fracture. And then again, once you get the abnormal stress in the bone causing the insufficiency type fracture or stress type fracture, then they get a fluid buildup in the bone, increased pressure, and that can lead to the osteonecrosis. And eventually this can go on to collapse, requiring a knee replacement. But when you see a light bulb bright condyle like this, I think of insufficiency type fracture with looks like developing articular surface collapse. First thing to do is look for a meniscus tear, because the meniscus tear, if the meniscus is not doing its job, can cause abnormal stress. They can start the first domino, where they get the insufficiency type fracture and the secondary osteonecrosis. If you don't see that, think about underlying causes such as alcoholism or steroid use, or just older age with a weak bone that's maybe causing the problems.
It is generally considered that a meniscus cartilage subchondral bone unit exists in the knee, wherein failure of any one component unavoidably affects the other two. Thus, any abnormality in this functional unit caused by meniscal and or chondral injury increases the load conveyed to the subchondral bone for which it is not equipped, thus leading to subchondral insufficiency and consequent fracture. Histologic examination of the failed subchondral bone reveals microfractures of the bony trabeculae and cell and vessels abnormalities that progress to focal necrosis after a few days. The necrotic tissue is then replaced by new trabecular bone. In some cases, this regeneration process is insufficient and the lesions are not reversible, resulting in collapse of the articular surface. Bone marrow lesion resulting from subchondral bone insufficiency may be detected in previously asymptomatic patients and in patients with previous pain due to earlier degenerative osteoarthritis. In the latter situation, patients complain of an acute increase in pain and manifest associated findings of effusion, functional limitation, and pain localized to the BML topography. Distinguishing between insufficiency fracture, Spontaneous osteonecrosis and avascular necrosis is important because their respective causes are quite different. Consequently, the principles underpinning their treatment also differ. Avascular necrosis is caused by interruption of the vascular input, usually due to certain risk factors such as alcoholism, steroid therapy, clotting disorders, and chemotherapy. Patients usually exhibit multiple foci of necrosis affecting more than one compartment. Involvement of metaphyseal and or diaphyseal bone is common, and the signal characteristics are entirely different from those of sunk, spontaneous osteonecrosis of the knee. Magnetic resonance imaging findings in sunk are relatively reproducible and specific. Bone edema appears first, whereas the fracture line is undetectable. Possibly is associated with microfractures of the trabeculae bone not evident on MRI. With progression of the causative mechanism of injury, these microfractures coalesce to form the typical subchondral image characterized by low signal intensity on T1 weighted and T2 weighted images. When the mechanism of injury persists, impaction or collapse of the subchondral cortical bone and or cortical bone discontinuity may occur, whereby the fracture line extends into the joint cavity, which allows the intra-articular fluid to pass into the fracture. This phenomenon hinders consolidation and favors the development of pseudoarthrosis. Moreover, this series of findings is frequently associated with the development and worsening of chondral lesions. Although the medial femoral condyle is the area most frequently affected, lesions may also appear on the lateral femoral condyle and tibial plateau. In osteoarthritic knees, the presentation of BML is disproportionate, exaggerated, relative to the degenerative abnormalities, extending to the intercondylar area of the femur or anterior tuberosity of the tibia. The thickness and dimensions of the subchondral low signal intensity image are believed to correlate with the lesion prognosis. Lukowitz found that low signal intensity lines on T2 weighted images with length greater than 14 mm or thickness of more than 4 mm